Good evening to everyone. Good evening, everyone. Thanks to CCI for giving me the opportunity to moderate a panel discussion on such an innovative topic on EBUS. We had a thousand webinars on EBUS, but probably first times we have a webinar which will be discussing about the comparison of different types of EBUS scope which is commercially available. What should be done by a beginner to EBUS suit, and more importantly, what Dr. Sham will also agree, what Dr. Ravindra Mehta used to tell, you should be competent able to tackle the complications. So what complications we will anticipate and how to deal with the complication. We have an excellent panel of panelists with us. So first I will request Dr. Jayakumar to go through his talk. We'll have Dr. Mihir's talk, and then we will all assemble together to have a candid discussion about different types of EBUS scope, complication, the physics behind the different types of scope as well as needle, and how to the complications. Thank you, Dr. Jay.
Thank you so much, Dr. Devraj sir, for the kind introduction. At the outset, I would like to thank CCI for coming up with this wonderful EBUS webinar series. And today I will be talking on EBUS physics and scopes, what we need to know. So we all use EBUS. We have seen in previous chapters about the utility. But let's get a bit more theoretical and understand what actually EBUS is. Well, we all know it's a bronchoscope with ultrasound. And what the ultrasound is, it's basically a sound with a frequency of more than 20,000 hertz, that is 20 kilohertz. And ultrasound uses transmission and reflection of mechanical waves at tissue interfaces to produce audible or visual signal. Ultimately, ultrasound is a wave, and it has all the property what a wave has, like frequency. So number of wavelengths in 1 second, which is measured in hertz, and it is determined by the sound source, which is dependent on the thickness of the polycrystalline ferroelectric material, typically a lead zirconate titanates, which is inside a piezoelectric transducer, which vibrates and it converts electric energy into mechanical energy, generating a pulse echo. And what is a wavelength? It is basically distance between adjacent bands of compression and refraction, which is measured in the meters. Coming to the wave's speed, which is a propagation speed, is denoted by C, which is frequency times wavelength. So propagation speed depends on medium through which the sounds travel. It is faster in solids versus in liquid or gas, where the velocity is dampened. So lambda, that is wavelength, is directly proportional to propagation speed. And it changes its speed of sound at tissue interfaces, which results in the change of wavelength, determines image contrast and resolution, which we see on the images on the monitor. A power is amount of energy passing through the tissue in a unit of time, which is expressed in watts, which is fixed in an EBUS scope. And intensity, which is energy per unit area per time, it is expressed in watts upon centimeter square. It's the intensity of a returning echo relative to transmitted echo measures relative intensity, which is expressed in decibels. Together, power and intensity are measures of a strength of the ultrasound wave, and we will see how to modulate this strength in the next coming slides. So what is a basic principle? So a piezoelectric substance, which we'll see in an EBUS scope, there is a ultrasound transducer, it generates a beam, which is seen in this part. And once this incident beam, it moves forward, it reflects, sometimes like a mirror, and it comes back to the transducer. Then sometimes it refracts, means it changes its direction. Sometimes it gets scatters and gets lost in some different directions. And then again, it attenuates. Slowly, it gets absorbed because there is loss of energy. So acoustic impedance, which is denoted by Z, is the density of tissue times propagation speed. It equals vibrations transmitted through the tissues, which echoes back at the boundaries of the tissue with different Z. When boundary between two tissues have high Z, most of the ultrasound is reflected back to the transducer, while boundaries of the two tissues of same Z will not produce echo, and you get the similar image. So acoustic impedance is one thing which separates the different tissue and gives the different contour or different grayscale which we are seeing on the images. And it is also dependent on the angle. So the percentage of transmitted echo reflected bells also depends on the angle of incidence. So it becomes very crucial how we put our scope, how we angulate our scope and get the image. So the acoustic properties of different media or the density, it depends on the attenuation. Here we can see that both the images are taken at 7.5 megahertz of the ultrasound frequency. Well, you can see the darker or the more blackish blood and somewhat grayish lymph node and more whitish, which is a lung tissue with the depth of 4 centimeter. Coming to the beam attenuation, which depends on the medium through which the wave travels plus frequency of the wave. So low frequency equals more depth and high frequency equals more resolution. This chart depicts this beautifully that if you keep the frequency low, you will penetrate more higher, but then you will lose the vision. If the frequency is high, there is more clarity in the image, but the penetration is low. So we can see it here that in radial probe EBUS, we have a 20 megahertz frequency. And what we can see is a clear and sharper image. But in a linear EBUS, we have 7.5 megahertz EBUS. And what we see is a bit less clearer image than what we get in the radial probe. Coming to the quality, how to adjust the depth. So, well, we all see that how much the node size is on the CT scan, and we try to mimic it with the help of EBUS to get the same diameter. So here we can see how to adjust the depth. Here what we can see is a 5.1 centimeter depth, and we see the subcarinal node looks like this. And when we try to put the EBUS needle inside the lymph node, we always keep it around 3 centimeters or 4 centimeters so that we can get a beautiful idea how much we are penetrating and how much we are getting the sample. So adjustment of the depth is very much important. We should at least keep the depth so that we can see adjacent vascular structures as well as needle which is in the lymph node. So ultrasound beam is a cylindrical near transducer and has a focal zone like a camera. So B mode is a brightness mode, which is the visual representation of an echo signal we receive. While M mode is a motion mode, which allows precise measurements of size and distances, which is more useful in the cardiac echo. Now we have talked about the propagation speed and the power and the strength of the signals. So gain, which is overall amplitude of the received echo, which adjust it to make the picture more white or the black. So here we are seeing the same structure with a different image quality. Here this is an optimal image where we see blackish blood vessel and whitish lung. And here we can see when we decrease the gain, we decrease the brightness of the image. And when we increase the brightness, and even blood vessel looks more whiter, which is anechoic in the optimal image. So we need to keep adjusting the gain according to the brightness what we perceive. And it also depends on the monitor's pixel quality too. So it depends also on what image processor you are having and what TV monitor or image monitor you are using. Depending on that, we need to adjust it. Coming to a very important aspect of the EBUS bronchoscope is Doppler, which with the change in frequency in the wavelength is perceived by an observer moving relative to the sound source. So EBUS utilizes color and power Doppler and not the pulse wave or continuous Doppler to distinguish blood vessels from the lymph node. Here there is a critical demarcation that what we see is a red and blue is not equal to the artery and vein. It just means the direction of the blood which is moving through the blood vessel. And it also depends on where we are keeping our scope. So it is very important that what EBUS distinguishes on the color is basically the blood vessel or a vascular structure from the vessel-less structure. So echogenicity is actually the tissue's ability to reflect the pulsed echo. Here what we are seeing is an isoechoic lymph node where we see the whiteness is similar to the lung. While here the lymph node is there, but it is hypoechoic, where the surrounding tissue is more whiter than the lymph node. Then here there is a cartilaginous structure which is more white than the surrounding tissue and which is called hyperechoic signal. And finally, what we are seeing here is a cyst which is anechoic, which is basically a fluid density, which is far more blacker than the surrounding whitish and grayish tissues. So it is very important for us to write the echogenicity of the structure, particularly of the lymph node, what we are seeing, whether this is hyperechoic, isoechoic, and what about the homogeneity, whether it is homogeneously echoic or heterogeneously echoic. This is very important because different type of pathologies have different type of echogenicities. So let me give you a practical demonstration where there is completely dark in the body cavities. And with the bronchoscope, we can have the light inside the airways. But with the help of this sound wave, as is seen in this beautiful animation, we transmit the pulse, we transmit the waves and visualize the structures. And I think this will give us the fundamental understanding of what we are doing with this different learning the different aspects of this ultrasound waves. So based on the ultrasound characteristic, we can differentiate between the malignant and benign, or somewhat possibility of being it benign or a malignant based on the EBUS findings. So we divide in the size, the shape, margin, echogenicity, central hilar structure, and a coagulation necrosis sign. So as is depicted in this beautiful image, if the size less than or equal to 1 centimeter, if the shape is oval, if the margins are indistinct, if it is homogeneous, or if the central hilar structure is present and coagulation necrosis sign is negative, is there, then it means that this can be some benign pathology, while all other it may indicate the malignant potential or a pathological potential. Coming to the vascularity, which is very important because we don't need bloody smears and TBNA sampling. So once we put the EBUS scope, what we see is grade 0 vascularity. There is no blood vessels inside the intranodal vessel. Grade 1 is hardly some, that is mainly in the central hilar structure. Grade 2 is few here and there blood vessels, and this is grade 3 vascular structure where there are so much of blood vessels. And then there is a BA inflow sign which we usually appreciate on the EBUS findings. And based on that, we have with incorporation of benign features and malignant features, where we see the more the vascular the lesion is, it can have more potential of being it malignant. And final mode in some EBUS scope they are giving is of elastography, where we can differentiate the stiffness of the lymph node and we can identify the area where we can get the more samples. However, just the presence of a stiff or a soft node doesn't indicate that the pathology is benign or malignant, and we still need to sample the node, which is very important. Coming to the artifacts or image distortions, which is caused by the normal phenomena of refraction, scattering, and attenuation, it may interfere with ability to properly identify the ultrasound target. It can be useful because they help describe the properties of the tissues and calcification and necrosis within a lymph node. So this is a common artifact which we have when we use the balloon. It is called the reverberation artifacts, which is a strong false echoes appear as multiple equally spaced lines. So it means your balloon is more inflated and we need to shrink it a bit. And here this is a beam attenuation sign or a tadpole tail artifact where there is an interlobar artery and the beam is attenuating. And then there is acoustic shadow artifact where we are putting a needle and we are seeing some reflection to that. Now, this is very important that whenever we are using a scope, we are familiar with the angles. So first and foremost, there is a visual angle, which is a 35-degree forward oblique. So it is not like the bronchoscope that what we are seeing is actually there. We need to bend our thumb up and down to get some things, the central, what we are seeing. And there is a visual field of 80 degrees, which is beautifully depicted here. And the ultrasound angle of view is a bit less. It is around 50 degrees. And what we need to position is that we have the lymph node in this ultrasound angle of view, where we have that we have it completely in the center. And to get better opposition, we usually use the balloon so that we have very good study of the homogeneity and the structure of the lymph node. So coming to the part how it differs in different types of scopes. Coming to the evolution of the bronchoscope, first we had the radial EBUS. This is a probe, a radial probe, which got started in 1996. And then there was development of a dedicated EBUS bronchoscope, which is also called a bumposcope, the first prototype. Here you can see there is hardly any angulation, and the needle was going straight forward like what we do in conventional TBNA. And hence it required some modification with a development of some curvilinear EBUS transducer, and then there is shooting of the needle at an angle, which is very important to set the angle when we pierce the lymph node. And I think this is the bronchoscope, which was the second prototype, which we are still using and having it in our armamentary. Coming to the needle system, so we have dedicated EBUS needles, which has a particular lock, then the guide sheath, which protects the sheath, and then now we are having a serrated tip with different gauge diameters like 19 gauge, 21, 22, and 25 gauge. Then there are Procore tip needles. I'm not spending much time because it's already discussed in the previous webinars. So ultimately, the thing is that we need to have a locking system, then adjustment of the sheet, and finally shooting the needle into the lymph node to get adequate sample. Coming to the different companies which manufactures that, there are three companies at present in India, like Pentax, Fujifilm, and Olympus, which are having different types of scopes. Coming to the Pentax has this beautiful system of an ultrasound, EBUS EB1970 UK Pentax Medical. They have outer diameter of 6.3 mm, working channel of 2 mm, 45-degree forward oblique view, 120-degree flexion and upwards, and 90-degree flexion downwards. Here there is important concern that because they have Hitachi ultrasound, you need to have PNDT, PC-PNDT low, which may not be used in other because they are not using this complete dedicated ultrasound unit. Coming to the Fujifilm scope, they are having ultra small CCD chip. They have outer diameter of 6.7 mm, working channel of 2 mm, optics 10-degree forward oblique view, tip angulation 120 degrees flexion upwards and 90 degrees flexion downwards, and wide field of view, that is 120 degrees. And finally, the Olympus system, which uses CP EBUS of outer diameter of 6.9 mm, working channel 2.2 mm, optics 35-degree forward oblique view, 120-degree flexion upwards and 90-degree flexion downwards, and there are different processors. This is a rough summary of comparison. Here we see there are two Olympus scopes. One is a thick scope, which is 180F series, and then the thin scope, which is 190F series. The difference is in the outer diameter at the distal tip, that is 6.9 mm in the 180 series and 6.6 mm in 190 series, which is claimed to be superior for reaching to the difficult station like station 4L. Why it is very important that we have a 35-degree or a 10-degree forward viewing, forward oblique viewing is beautifully depicted in this. So if we are keeping the scope here, what we are seeing is this vision. But we need to target the enter commission, and then we can go ahead. I'll repeat this animation again so that we can understand it more beautifully. That we are keeping near the vocal cord. Here, usually we go into the posterior commission, but because of the difference in the forward view, oblique view, we need to keep our thumbs down and target the enter commission, and then we can go ahead and insert the EBUS scope into the trachea. So highlighting the tip and the differences between 180 and 190 series, and as it is claimed, as I mentioned earlier, that 190 scopes can lead to the better positioning at a difficult session. A final word about Riddle probe, which is basically a probe which has a dedicated ultrasound transducer, or called a driver probe unit. So there is a rotating mechanical transducer which has a 360-degree to the long axis of scope, 20 megahertz. Tissue penetration is less, like 4 to 5 centimeters, but image quality is very good. But only thing is we don't have a Doppler, and we don't have real time in that, which we have in the linear EBUS. So this is probe which goes from the Scopy channel. With that, I will end my presentation. Thank you all for patient listening. Thank you, CCI, for giving me this opportunity to present. Thank you.
Good evening, everyone. My topic for today is EBUS complications. I'm Dr. Mihir Gangakhedkar. I work at Fortis Hospital, Mulund. And I thank all of our CCI dignitaries for allowing me to speak in this EBUS webinar series. So I've called it the infrequent, the rare, and the catastrophic, primarily because EBUS related complications, it's considered to be a predominantly safe procedure. So when I say this, I start off with a dramatic slide of something that someone hopes, everybody hopes it doesn't happen to anyone really who is performing such a procedure. But at the end of the day, something what happens. Possibly the only thing that one can do is eventually report it and let your colleagues know that these things can go wrong. There have been several international data sets looking at complications related to EBUS, and this was one of the earliest ones in 2013 when Asano and colleagues produced this paper, where they looked at nearly 7,000 and more procedures, and the rates are reasonably low, 1.23%. And that was a retrospective study. In a prospective study around the same time, from chest, we had 1.44, and even our Indian experience from Sejal sir's team showed a 1.1% risk. So we're looking at a procedure which is relatively safe, low chances of complications. And when they try to identify, we want to know as to which patient is likely to complicate. The acquire registry from chest showed that if it was an older patient, the patient had been admitted for whatever reasons before the procedure and wasn't an option as such. And if you used a higher level of sedation, you're likely to have some form of complication. Similarly, the study by Asano and colleagues also gave us one more factor that obviously, if you're in the learning curve, if you've done less than 50 cases, you were likely to be in the group which had the complications rather than the ones which did not. Broadly, if we are to classify our complications, one would call them anesthesia related, your procedure related, infective or non-infective, and finally, something related to your assembly itself. Anesthesia related complications are not really ones which one cannot foresee. We know that hypoxia, hypotension, arrhythmias, if you've not got a well protected airway, aspiration, if the patient is not well sedated, continuing to cough, those complications are something that we know of. And as should be the case in our patients, the risk factors are those patients who have been requiring oxygen even before they, underwent the procedure. If they had a parenchymal disease, which essentially gave them a risk factor for an anesthesia related complication. And also on table, if it was found that if these patients had required some form of bronchodilation, you are likely to find some complication for these patients eventually. Our anesthetists tend to prefer some drug over the other, but when they tried to look at it as to whether there was something that was safer than the rest, they could not really identify one particular thing. When we are looking at intervention related complications and the infective ones, you have pneumonias, mediastinitis, pericarditis. If you've tried to sample a mediastinal cyst as an expert, then there's still a possibility of an infection. They looked at this in a large 10-year registry from South Korea. And again, these complication risks were less than 0.5% in a large 6,800 plus sample size. If one were to try and predict what causes an infective complication, which patient is likely to have it, and it was more likely if you had a necrotic or a cystic lesion, something that one finds intuitively a possibility. And additionally, if there was a combined EUS-B FNA, they found that the odds of having an infective complication were higher. Remember, these complications are likely to occur later after the procedure, not something you may identify immediately. It took about a week after the procedure for them to present. And as pulmonologists, we are adept at identifying, nosocomial pneumonias or patients having a new onset pneumonia. But even in our group, we found that mediastinitis was something that was identified later. It took 9 days for identifying mediastinitis as against 4 to 5 days for coming to conclusive proof with a pneumonia. So nearly 100% longer time for mediastinitis identification. And the course of treatment obviously is a lot longer with more antibiotics. And this particular image is from one such patient who they tried to sample with EUS-TBNA, and eventually the patient did develop a mediastinal abscess, which they found out later when they did another repeat scan. So uh, it requires a threshold, a good threshold for trying to identify this complication. One doesn't think too frequently that pericarditis is something that could occur with a patient who's undergone an EBUS, but this was something that was published, and this is something that one really needs to look into, that pericardial recesses could sometimes mimic lymph nodes even on your ultrasound. And one of my juniors from MBBS days, who's now working in the USA, published this report. And in this report, the patient did develop pericarditis. And if your patient post-procedure has significant chest pain, fever, and you go at an ECG and you find diffuse PR depression with ST elevation, think about pericarditis. This is a good paper to read, and it gives us, a good reading into the fact that if you are going to do a procedure, look at your images carefully. If you look only at your axials, you're likely to miss out on some that just as brilliant note. So that's something that is the learning lesson from this. From the infective, we go to the non-infective complications that we look at. And in the non-infective complications, you have hemorrhage, the rarer fistulae, pneumothoraces, mediastina, or pericardia. And we come back to this dramatic case that was published nearly 5 years ago. And this patient actually went back home after the procedure and came one day later with massive hemoptysis. And even though it is the commoner non-infectious complication, remember the numbers are still less than 1% in both of our large registries, which are cited most frequently. But are these numbers likely to pick up with the increasing advent of cryobiopsy? Possibly time will tell. For people who are starting with doing e-buses, our Indian guidelines are obviously there to help. And remember that you can continue on aspirin. If you're thinking of doing a procedure in a patient who's on clopidogrel, you will probably want to speak to your cardiology colleagues. Is it really necessary to continue the clopidogrel? If yes, then that's a risk you'll have to take. But if no, then probably wait for 5 to 7 days. Anticoagulations have their standard durations of stoppage before you do procedures, so those you want to respect. And while platelet counts and coagulation parameters need not be done in all, is what the guideline says. It's rare, possibly in real life, for you to have a patient without these parameters before the procedure. And this was just 2 years back, where one of an Indian heritage professors in HLH, who had HLH himself, actually passed away after an EBUS in the UK itself, and with bleeding, hemorrhagic complications. And so this can occur, and this can happen to practically anyone. The other rarer non-infective complications would be pneumothoraces, fistulae as such, but all reasonably rare even in the large studies. And you would rather find them more commonly when you're doing it with an accompanied procedure like a transbronchial biopsy as well. And we come to malfunction of assembly, and we'll talk about it slowly. And this is something that has just in January 2026. And while it's redacted like a lot of the Epstein files, you can find this online easily. And it's a fact of life that your needle assembly can break. So in India, we tend to respect finances much more given our lack of comprehensive insurance coverage. But when you're reusing needles, reuse them with caution. Before you use the needle, you want to test fire outside as well, just to see that there is nothing that's breaking immediately. If it's a calcific node, you want to use your needle with caution, it can break. And finally, when a complication occurs, it may not be you, it may be the needle. And that's evidenced by this large scale recall that occurred recently. So if it happens, please report it. Maybe you might help a colleague from facing a similar fate. Again, something that's never happened to me, but this is something that was reported where while they were trying to use an EBUS in a patient who was intubated, probably because of rubbing against the ET tube lower edge, eventually the balloon dislodged and they had to remove it. Had they not really checked the scope appropriately, the balloon could have remained behind and could have caused something. And finally, scope damage, something that we're all afraid of. It's an expensive issue. Your scope gets damaged. Eventually, you are losing out on doing procedures, the cost of getting the scope repaired, whether it will get repaired or not. You feel, why has this happened to me? But even our Indian survey that we did 70% of scope damage was a real problem. And obviously, throughout our data sets, we find that it's more in learning curves. And if you have larger volumes, this is likely to occur. In summary, I would like to bring this article to notice. It's got a very deep thought. Complications are inevitable, but suffering is optional. And I'd go one step further and probably say that suffering is probably necessary, but how you suffer is what is more important as to whether you manage to learn from it better versus you become what the article says, a second victim of a complication. So, as your numbers go on, you are likely to face some form of complication for sure. And you can try and be prepared as much as you want, learn from the possible problems or missteps that have occurred already, learn from seminars like these, and eventually turn out to be a better interventionalist so that you can serve your patients better and also not become second victims yourself. So, thank you for the patient listening. And like factories put up number of days since there's been an accident, if I were to put this up in my own bronchoscopy suite, it would be only a single day. I've just received my lonoscope yesterday, so no complications since the lonoscope has arrived at least. So thank you once again. Thank you for the opportunity, and I look forward to the panel discussion further. Thank you.
Thanks to both Dr. Jayakumar as well as Dr. Mihir for their wonderful presentation. Now we are going to the panel discussion. Dr. Vishwesh, are you there?
Yeah, I'm there, Dr. Debraj. Yeah.
So I will start straight away with Dr. Vishwesh. So suppose someone has passed MD and he's now planning to, he has joined a new institution which doesn't have any kind of facility of EBUS. Now he has called you, Dr. Vishwesh, please suggest me, I want to set up an EBUS unit. So what are the prerequisites which I need to fulfill before I will buy a scope? Dr. Vishwesh.
So, EBUS luckily has got a very easy learning curve, unlike other aspects of interventional pulmonology like rigid and cryo, because the safety aspect with respect to the EBUS scope is only with the damage to the scope more than to the patient. So generally most of the complications related to the EBUS happen to the scope. So I would feel like before you start venturing into the domain of EBUS, if you are a novice, you have to be extremely confident in doing the basic bronchoscopies. That is point number one. Then only you should start venturing into EBUS. Second thing is you need to have attended at least 3 months of practice in a high volume center. When I mean high volume, at least you should have individually done 20 to 30 EBUS and you should have assisted at least like around 50 EBUS along with a proctor, so that you are very confident when you start handling the EBUS scope. And third thing, you need to have a good understanding about the ultrasound knowledge, because many a times you think that you directly jump into a EBUS, but having a basic understanding about the principles of ultrasonography will come very handy when you are dealing a lesion, like suddenly you encounter a bronchogenic cyst or you encounter a blood vessel, you will understand what Doppler is when you are using the EBUS. So having a basic knowledge of thoracic ultrasound is also important before you actually start thinking about procuring an EBUS and starting your independent program. And the fourth important thing is you need to understand the technical aspects of the EBUS. So many times as a IP beginner, you would love to jump into doing a practice. But thing is, you need to know the technical aspects of the machine and the probe. So sitting with the company, whichever scope you are using, and understanding from the technician about all the details pertaining to gain, what is meant by gain, what is zoom, what is depth, and how to measure the lymph node, and how to individually handle the scope, wash the scope, and handle the needle. All these things are very, very important. Even though it looks small, these are the things where you need to give a lot of importance before you actually start procuring and start doing your EBUS by yourself. So I think when it comes to the learning of the EBUS, more than the safety of the patient, which is because in fact the EBUS is one of the most safest of all the interventional procedure you can do. The safety of the scope and the protection of your scope from the needle damage are things which you should understand.
Said Vishwesh. Now I go to Sam. Sam, you have a lot of the trainees who are working with you, both post MDs as well as the DNBs who are working with you. Now you have many aspirants who want to have a feel at the scope. So you need to tackle with the emotion. Now you also had an experience that whenever there are multiple hands which is working on a particular scope, both at the government setup as well as the corporate setup, the government sector, it will be much more difficult to maintain the scope. So at the corporate sector, at some point of time, you also must be rigid enough. And so what are the advice which you give you to your younger colleagues so that they will be able to maintain the scope? Because once it gets damaged, it is very difficult nowadays even to have a loaner scope. And also it is very difficult to convince the hospital to again go for another, whether it is in the AMC or CMC, those kind of. So what are the things for everyone who is working, both for the trainees as well as for the us also? How do you maintain? What is there any protocol? Is there any system? What do you have in your institution?
So usually, you need to identify the trainees who can proceed to do an EBUS. Everybody has a learning curve. It's not that, a person at second year, he automatically becomes proficient. He can be eligible for EBUS. So I usually start giving second or third year trainees the feel of the scope and, the initial passes at the needle. But the first condition the prerequisite which I keep is knowing bronchoscopy very well. So if they're very good at the usual white light bronchoscopy, at least they should have done at least 50 to 60 bronchoscopies independently, after which I usually give them a chance to come to the EBUS procedures. And the EBUS procedures, initially, I just start with identifying the landmarks, and I usually do it with the LMA. So initially, because all of them, you get time to teach. If the patient is coughing in the conscious sedation, you always have the time constraint and you wouldn't be able to teach well. So I mostly, whenever if it's a teaching case, I use, and the patient is able to, is fit for a general anesthesia, I usually post it for a case with an LMA and under a GA. So then I can actually, teach teach my students the knacks of doing the EBUS. And the technician is very important over here. So because the technician has to train and he keeps a strict watch on the needle, the sheath. Even if the junior forgets, he would be the one who would point out that doctor, you need to leave the liver. So when you're passing the needle, the thumb should be off the liver. Otherwise, you'll end up puncturing the working channel. The sheath should be visible. You shouldn't overextend the liver. Use of the balloon. So there are certain stations like 4L or a paratracheal 2R or 2L, you need to flex the liver a lot. So that can lead to damage of the liver. So usually in those cases, we advise using the balloon. The sheath and you visualizing the sheath outside and not and ensuring that the liver, the thumb is off the liver when the needle is being put is there one of the most important steps to prevent scope damage. And if you're using and obviously the fitness, the sedation of the patient and localizing, so that are the steps I follow. So first, adapted bronchoscopy. Second, he should be able to identify the landmarks, and I usually do teach them with the LMA. And then taking the needle, doing the whole exercise of the needle passing, taking the stellate out, making smears, and all that. And then I usually give them as an independent procedure.
Again, well summarized, Sham. So now I will go to Dr. Ujjal sir. Sir, as you are aware of that fact that many of the patients of EBUS, particularly those who are having some kind of lung cancer or those kind of things, are also having COPD. And also in many a times the EBUS procedure usually takes around 20-25 minutes. So you are giving lot of sedation and those kind of things, and also because the patient is having a borderline lung condition, so the role of anesthesis becomes very critical. So what is your advice to the beginners? Because if I have done 100 EBUS already, so I will be smart enough to guide the anesthetist also. Also, I will have an idea of how much sedation I will dictate the anesthetist also. But for the beginners, how they will prepare themselves for the any kind of anesthetic complication, which is the most frequent complication. I think all of us have encountered some kind of oxygen level going down or those kind of things. So what is the basic level of expectation from an anesthetist, and what is the basic level of knowledge regarding the drugs which a pulmonologist should have? Ujjal sir.
Thank you very much. Well, anesthesia is very, very important, especially when you are beginning to do the EBUS. The reason is that whenever you are trying to identify and then make a puncture into the lymph node, if there is too much of respiratory movement or coughing, then you might injure the patient or damage your scope. So these are therefore you in especially in the beginning you should be doing should be doing with the help of anesthesia people in deeper sedation or through an LMA, so that the breathing pattern and as well as the depth of breathing and coughing is controlled. So that will help you in focusing more on the procedure rather than on the comfort of the patient. That will be taken care of the other by the other person. So that is very important, especially when you're beginning. Once you have done few procedures and you're very well understanding, you yourself are confident, you can handle the minor depth of breathing or minor coughing, then you can start doing it under local anesthesia. But whosoever is starting to do it, do first under the backup of proper anesthesia and probably an LMA. So that is one thing which I want to say. The other thing is that yes, this procedure is longer than maybe a normal bronchoscopy, and therefore there is a possibility of because of being a prolonged procedure, there is a possibility of hypoxemia, there is a possibility of CO2 retention, there is a possibility of arrhythmias happening because of the various drugs or as such whenever patient is more sicker, and there can be complications because of the drugs. So these are all possibilities that can happen. So usually what we are doing in our setup is whenever we are trying to do staging of the lung cancer or a staging of these lymph nodes, the procedure we expect is going to be longer. At that time, we are definitely doing it under general anesthesia or LMA. And when we are just trying to take a sample from single group of lymph nodes or a larger lymph node, we go ahead and do it in the local anesthesia. That is one thing. The other thing is that we are using HFNC I don't know whether it's freely accessible to everybody or not. We find it very comfortable for the patient to maintain the oxygenation for especially in a longer procedure by giving HFNC through the nose, so that maintains the oxygen levels in the patient. So that is also one thing. Though it has a caveat that it's not a full control of ventilation. So possibly in patients who are COPD patients or who have a history of CO2 retention, the CO2 levels can go up. So therefore, there should be a CO2 monitor also attached whenever we are doing HFNC, the procedure under HFNC. The knowledge of drugs, see, as you keep on doing the procedures, you are getting the knowledge. And same way, the anesthesia people are also getting the knowledge about the procedure. So they also grow along with you. So it's a teamwork. So identify a set of anesthetists who are going to be assisting you, and as you go forward the both team understands each another, their requirements. Your requirement is a calmer patient who is not moving too much, and their requirement is that you are not doing a procedure where they have to give too many medications, or they don't have to give too deep a sedation, or they do not, especially in patients with COPD, they do not give a sedation, so much sedation that the respiratory rate goes down. So that can increase the CO2 levels. So these are certain things that need to be kept in mind. But as you keep on doing the procedures, you keep on growing on them, and then you can prevent all these kinds of complications very well.
Yes, Ujjal sir. So now I will go to Dr. Jayakumar regarding, as Ujjal sir already told you. So what is your way of doing the EBUS? Or you do all the EBUS through LMA, or even you do EBUS in many cases without LMA, or you use HFNC? So what is your way of doing the EBUS of airway, protecting and securing the airway?
So I thank you so much for this excellent question, sir. So I work in a private practice in a corporate setup. So for us, many of the patients who come here, either they are paying self-paid or they are in insurance. So for us, the paramount importance is to give the yield. And that is one of the most important aspect which I'll add to Dr. Vishweshwaran sir's answer, that our entire infrastructure while setting up the program is and it should be focused on getting good yield, whether it is a positive or it's negative, but we have to be very confident that we have taken very good sample. And for that, I think where I practice, because we have a time, infrastructure, availability of anesthetists, sharing of the suit with the endoscopy persons, and having plethora of the needles, availability of cryo probes, I usually give a dedicated time around one and or up to 1.5 hours to my all EBUS patients, because we need to get good and thorough evaluation of almost every aspect. So we need a calm patient where we have very good secured airway with LMA. This is our usual practice. We have anesthetist by our side. We give a lot of time to understand the EBUS morphology of the lymph nodes. Although a CT or PET scan may reveal around like subcarinal or right lower paratracheal node, which is an easy target, but still we see that whether there are other lymph nodes which are having peculiar characteristics or any other EBUS findings are there or not. And based on that, we take our time, we measure the size of the lymph nodes, presence of, as I mentioned, central hilus structure, coagulation necrosis sign, where to avoid, particularly of the vascularity, adjacent structures vascularity. And once we have very good pass, we always have pathologist by our side for a rapid onset evaluation, which gives us the feasibility whether they will be able to give confident diagnosis, whether the cellularity is there or not, whether the samples are initially what used to happen, that we would getting lot of bronchial epithelial cells. So and we have very good chunk, but then it's a preponderance of the bronchial epithelial cells, and the Rose person was telling us to give more and more pathology specimen, more and more passes. Sometimes even after reaching 6 passes, if we are not able to get good and enough specimen, and we don't have any other lymph node to be sampled, then we convert it into either EUS-BFNA or EUS-FNA. I will share a recent experience where because we didn't have 19 gauge needle availability, our gastrology colleague had that 19 gauge needle. And because of that, because it's the big needle which passes through the US scope, we need to convert it into that and then we get the yield. So it might not be feasible for all. In private practice like us, I usually prefer, as Dr. Sham sir told, we usually need calm patient who is good sedated, having LMA, and give good chunks so that we can give the good yield, and the procedure is not to be repeated. So, sir, although this procedure can be done under a deep sedation, sometimes in borderline cases, even in conscious sedation, but I prefer to do the procedure under LMA for the sake of the best yield to my patients, sir.
Thank you, Dr. Jayakumar. Now, Dr. Mihir, among the agents or sedative, like among the midazolams or fentanyls or propofol or dexmet, so what is your choice of agents? And which agent is particularly notorious for the complications in your experience?
Good evening, sir. So, actually, as far as procedures are concerned, while we did the procedures while we were training, we did a lot of these procedures on our own, which were bronchoscopist mediated anesthesia. And so it was conscious sedation primarily. We were using midazolam, possibly some amount of fentanyl as per whatever was required at that point of time. In my present practice, I have the fortune of having an anesthetist at hand. If the patient is likely to be able to sustain a good amount of anesthesia, then we generally do it under LMA, or else in patients who are borderline, again, we do it under conscious sedation with local anesthesia. What medication do we use? So when we're using a patient on LMA, we've been using propofol more frequently for our patients with the anesthetist at hand. And when the patient is in conscious sedation, then we're trying to use fentanyl more commonly than others. So as far as when do you have a patient complicating more frequently with which drug? We've had hypoxia actually, unfortunately, with any agent really, as in if it is to occur. I haven't really found one of our agents giving us more hypoxia than the others because possibly because I have the anesthetist actually titrating it better than me needing to really think about which drug and how much they have given. But generally, so in our practice, we have propofol with our LMAs, otherwise fentanyl with some amount of midazolam in conscious sedation.
Now going to some more controversial questions. So I will start with Dr. Vishwesh. So there is no financial interest or any conflict of interest there. But first I will ask Dr. Vishwesh about among all the available scopes. So if first you just tell us the advantages and disadvantages of all the three available EBUS scope. I am talking about the linear EBUS scopes. And which one do you rate highly and which one do you recommend for any beginners?
Okay, so this is a very controversial topic. Okay,
and we will send this recording to all the manufacturers.
So I know you did it intentionally, but anyways, I will say that. Okay, see, to be honest, it entirely narrows down to the person with which scope he has got trained. I feel that way. It is not like
we don't want a diplomatic answer. We want a
I am giving you all the answers. Just allow me to speak. so okay, see, me personally, I have had experience of using both Olympus as well as Fuji. And Pentex, I have tried using it initially mainly in conferences. I have never used it in my center as a standalone scope. So I can comment on both this Olympus and Fuji extensively. So that when it comes to the EBUS, the problem with the EBUS is there is an angulation. Unlike your traditional bronchoscope, where you have a 0-degree vision, whenever you use an EBUS, you always have an angulation because of the ultrasound processor at the tip of the scope. So the Fuji, the advantage is it has got a very low angulation. So when you start using Fuji, you really feel like you're almost using your routine scope. You won't get the feel of actually using an EBUS scope per se because the angulation is almost very negligible. I think it is, if I am not wrong, it's 10 degrees or something. I'm not very sure. I think it is around that. So you really feel like when you're negotiating the vocal cord, the anterior commissure of the vocal cord, you really feel like you're using just your routine bronchoscope. You don't feel like using the EBUS. Difficulty in uh, having to learn that extra angulation with an EBUS scope. That is one advantage. The second advantage of the using the Fuji scope, which has got a less angulation, is once you pass the needle, you can see the sheath actually coming out very clearly. Because the angulation is very less, you can see the sheath of the needle coming out very clearly. So your chance of actually damaging the scope because of an accidental puncture by the needle is relatively less. The third thing is when you are doing an intranodal cryo, so you wanted to pass your either your electrosurgical knife or a 19 gauge needle. Again, this relative low angulation of the scope makes it like little easier to pass the electrosurgical knife or the 19 gauge needle. And similarly, when you want to pass the intranodal cryo probe, the 1.1 millimeter cryo probe, then also it becomes less easier. So these are the, I feel like relatively advantages of the 0-degree scope because of the angulation, advantages of the Fuji scope because of the angulation of the ultrasound processor at the tip of the scope. When it comes to the Olympus has its own set of advantages and disadvantages as well. In Olympus, the thing is the angulation is on the higher side. You have like somewhere around 30-degree angulation, if I'm not wrong. So the disadvantages, sometimes you may find it little difficult for you to get used to the scope initially, because you will find that you're not having a 0-degree vision and you have to go past the scope, focusing on the anterior commissure of the vocal cord to enter into the trachea. That is one thing. Second thing is, whenever you wanted to pass these intranodal cryo probes for doing the intranodal cryobiopsy, if you want to pass the 1.1 millimeter cryo probe, sometimes you can find it little difficult in maneuvering. And third thing is, when you wanted to pass an electrosurgical knife, again because of the angulation, you can find it little difficulty. And the fourth thing is to identify the sheath, because it comes at an angle, it can become a little difficult. But having said that, if you have already started using an Olympus, it is relatively quite easy to get adapted to these changes. It is not that you need to have only this sort of a scope to do a particular procedure. For example, the current center where I am practicing right now, we are doing more of Fuji because that is the instrument we have. But previously, I was working in the same organization in a different unit where I was using Olympus. It doesn't mean that my yield of the procedure, like the EBUS procedure, has changed or anything. We are getting the same yield. We are able to target the same station of lymph nodes. We are able to target the same centimeter size of the lymph nodes. So I don't think it is the scope, it is the person behind the scope that matters when in getting a diagnosis. So even for example, we run a fellowship program where there are like so many fellows, I think around 15 fellows are there, and they get trained. They get trained in a particular scope, but when they go outside and they start using a scope from a different manufacturer, they don't find it difficult because they know the anatomy properly. They know the technical details of the scope properly. So they are able to get adapted within a day or two and start doing it. So I think again, it ended up in a diplomatic answer, but that is the genuine thing. You don't have an advantage of one scope over the another. And it entirely depends upon your comfort, and the yield entirely doesn't depend upon the scope. It depends upon the person and the level of competence he or she has. So I don't think just because somebody is doing procedures in one scope and putting it, it doesn't mean that you have to purchase the same scope. If you are a very skilled person, you can get the similar yield, you can target the same set of lymph nodes with both the scopes. And regarding the Pentax, the advantages, Pentax comes with a dedicated ultrasound machine. So the image you get with the Pentax scope is supposed to be equivalent to that of what you get in an ultrasound machine. But unfortunately, we don't. I have not purchased one, so I have not used it one as a standalone scope. But in conferences, we have seen and we have used it, and that is also quite a good scope. End of the day, I think what narrows. I'll just finish it in a minute because I don't want to take much of the time. So if you are buying a scope, you try all, and you feel which one you are comfortable with. And generally, the scope which you got trained with will be the one you are most comfortable with. And second thing is, whenever you're buying a scope, make sure that you have compatible needles. Sometimes in your pharmacy, there may be one set of needle which may not be compatible with another scope. So find out you are purchasing the scopes with the compatible needles. And the third thing is, always request these people for a complete warranty of the scopes, because sometimes you may be good at your procedure, but if your technician is not good at maintaining the scope, it can result in a scope damage, and that becomes a very complicated scenario. And the fourth thing is, cost is the ultimate factor, because you need to justify the investment that you make. So let's say that I already have a Olympus monitor and a Olympus stand. It just because I wanted to do with some other scope is little benefit. I need not change it because the yield or anything is not going to change. So if I already have a Fuji monitor and Fuji setup, it doesn't make any sense in unnecessarily purchasing another one, because it is not going to change the yield or it is not going to change anything. And within a day or two, you can get adapted to using these scopes. So I think you need to be very practical and in choosing your scopes, rather than just getting carried away because somebody is doing with that scope. So this is the honest answer.
Well said, Vishwesh. Now I'm going to Sham regarding just in continuation with what Vishwesh said. So the same question, but with more emphasis on the needles. So do you have any fascination for any particular type of needles among all the needles available? Number one. And number two, also between the earlier needles, like suppose Olympus, the earlier needles or nowadays the needles what we are getting. So your experience with the needles.
So I'll tell you, thanks. So we've got two sets. So we've got Olympus as well as Pentax. And both work with different sets of needles, but they have an adapter with which you can interchange the needles. But Olympus, I'll start with Olympus first. So the Olympus, the initial VisiShot needles which we got. So the issue with that was, especially during training while teaching students, I learned in Olympus, so I found it comfortable starting with that. But then I find Pentax to be equally good because they have a separate monitor for the endobronchial view and a separate ultrasound. So it's very easy when you get to see the landmarks clearly and you get a very good ultrasound view. Plus it has elastography, so which is an added advantage. It occupies more space in the bronchoscopy suite because you need to have two separate stacks. So those are the advantages and disadvantages of Pentax. Pentax has two needles which we commonly use. One is the Cook. We use the Procore needle, which has a small serration and it's used to obtain a core, which I feel is good. And plus you have the Cook, the regular needles, the 21 gauge needles, which you can you do your TBNA. You don't have a 19 gauge for the Pentax. Whereas for the Olympus, you have the VisiShot needles. You have the 19, 21, 22. So that advantage Olympus has. The issue with the Olympus needle is just that the sheath is transparent. It's white. So sometimes it gets, it's tough to notice the sheath, whether it's out, in, it retracts back in sometimes when you flex the scope. So that is, but now the newer needles which they've got has the colored sheath, because of which you can identify that. And the VisiShot needles off late were very notorious, especially if you tend to reuse them for causing breakages, and they have a spring inside which tends to get dislodged within the node, or if you're lucky, a part jutting out so that you can take it out even if it breaks. So those were the experience with this. Then, but the good part of the Olympus scope is that it's quite compatible with the Acquire needles of Boston Scientific. So the Acquire needles, they have the tri-shaped point in the needle, and you get a very good core with that. I mean, probably the best cores I get using a needle is with the Acquire, the Boston Scientific needles. They're very good. The issue with it is it's probably stiffer than the others. So if you are working with a 2L 2R needle, you need to flex a lot, and sometimes your apposition of the ultrasound with the endobronchial or the endotracheal wall is not too good if you fit the Acquire needle. But all said and done, I feel the best needle for obtaining cores which I've got is Acquire. They without fail tend to give a good core. But then at the end of the day, it also depends on the the expertise of the bronchoscopist or the EBUS specialist who is doing it. So that is my take on needles.
In just continuation, I will also tell my experience. When I first, my training with EBUS was also during my postdoctoral traineeship with the Olympus. So I also started with Olympus. Then I joined the initial private hospital where I used to work. Then I had the privilege of having the Pentax. And when I used Pentax, although I was much more comfortable with Olympus, I found it very much user friendly because, as you rightly pointed out, there are two monitors. You can clearly see, particularly for the smaller size nodes also, you can see. And also, you will all agree that because of the visualization of EBUS scope is not that great. And particularly after 3-4 passes, when it becomes more gloomy with the little bit kind of blood and all those kind of things. So there we have the advantage of two monitors, and Cook's needle also works very well. If you ask me my comparison with the Olympus needles and the Cook's needles, so probably the yield, and in many cases, particularly with the Boston Scientific, which I now use with the Olympus scope, you need not to do cryo in many of the cases because it gives a very good chunk in those subcarinal nodes where you have a big size node. So you many times you do not require even to do the cryo. And I did not have any experience of using Fuji, so it will be very difficult to comment about Fuji. I had experience of Olympus and Pentax needle. Fortunately, I had the experience of having all the three needles. So to all the panelists, in addition to Vishwas and in addition to Sham, any comment about the scopes or needles from your experience? What do you suggest? Any one of you, sir? Ujjal sir, Mihir, and Dr. Jaykumar, everyone.
Can I comment? Right. So the advantage with Olympus is comes with a complete ecosystem. It comes with its own processor, its own ultrasound machine, its own needles. So it's a complete ecosystem, while others will always have more compatible things available to them so that you can use them. So that's the advantage with Olympus. The only problem is Olympus has it's a hybrid scope where the endobronchial images that you get is of a fiber optic bronchoscope rather than a video bronchoscope. So the endobronchial images are little inferior to the other two scopes that we have, which are video bronchoscopes. And the reason for that is the Olympus scope is the thinnest one. So to make it thinner, to make video bronchoscope thinner, it's a little difficult. So therefore, they have kept the fiber optic bronchoscopic image. So that's one thing. Regarding needles, I think we have used all the needles, and we find that VigiShot is the most flexible needle. I don't know whether everybody will agree to that or not. They are most flexible when you're using a 21 gauge needle or 22 gauge needle. The flexibility is very good in reaching there because its sheet is probably the softest. So it's a little more flexible. This is what I felt. And then I have a similar thing to say about the acquire needle. It gives a good core, especially when you're dealing with a harder node. If you're dealing with a harder node, not getting good sample with a normal needle, you can always shift to acquire needle, which has got 3 prongs to cut into the tissue and gives a good sample in that.
Mihir?
So I've had an opportunity to use actually all three needles, and frankly, I have found the VisiShot, the earlier needles were reasonably okay. The newer needles which have come with the green sheath, there have been a few issues with the movement of the needle in the sheath itself. That was my personal experience. But yes, with your Boston needles, there's a good amount of core. Yes. As far as scopes is concerned, I've trained on Olympus. I have used an Olympus all the time. I've only seen Fuji's and used them in conference setups, and Pentax also in conference setups, but no personal experience with either.
So, sir, I agree with all the panelists. Only thing is, I also definitely agree with Dr. Ujjwal sir that the flexibility of VisiShot is very good. At 21 goes, VisiShot, it moves very good. And most of the time I've used 21 goes VisiShot and I've got all my answers. Very few, like I mentioned, very few, sometimes there are soft node, which probably is not getting, or something, sometimes there are very hard lymph nodes where I'm not getting, particularly with the benign pathologies. Then only I involve our gastro colleague, and then we might have to either try to some different approach or to think out of the box, that kind of thing. But otherwise, most of the time, around 95% time, 21 goes VisiShot gives the answer, sir.
And one more thing which I want to tell is that whichever needle we are using, statistically, they have not been shown any difference in the yield.
Yes.
Yield of all the needles are same. So I go back with what Dr. Vishweshan said, the person behind the instrument is more important. So whether you are using a 25 gauge, 22 gauge, 21 gauge or 19 gauge, the result is almost the same. So results are not different. The quality of material may be different. With 19, you may get more bloody sample. With 25, the needle may be more flexible and smaller lymph node can be easily targeted with that. But that's the only difference with the gauge of the needle.
Again, Sam, I'm returning to you. Like because of the competition factor, because of to look after the cost. So as you rightly pointed out, many a times we are reusing the needles. So because of the cost, the only reason is cost. So what is the maximum number of cases or maximum number of individuals in which you will recommend that it can be used?
So, so related to this, there was a study done by the PGI group regarding reusing needles. So there, I believe they found that though you can reuse it if you follow the strict practice of sterilization, but the yield decreases. So eventually, they say the cost, it catches up with the cost if you're trying to save money by reusing the needles. But nevertheless, I over here also we do reuse needles, but I don't think so. We go beyond 3 or 4 procedures.
Even third one, you will find it very challenging.
Yes, yes.
And you will always feel that while you are just taking the sampling, it is, and you have to press very hard, and you can feel it. So
Not only that, the needle bends also, and you're always worried
also,
about the needle breaking.
And I personally had experience of breaking the needle with this Olympus scope and needle. As you rightly pointed out, it just gets benched up, and it also had a screw-like thing, so it just gets dislodged. And particularly in the subcarinal region or those kind of region, it gets dislodged in the subcarinal area. So we should be very careful. We should look after the cost, but not at the as you pointed out, not only the yield, but also to remove the needle, and to it will create at least a chaos in the procedure room. 20-30 more minutes will be taken to remove that. So we should be careful not only to the scope but also to the patient. Now, another question what I will ask every one of you. So now coming to the complication, we always know that the most common complication while doing EBUS is the bleeding. So how to tackle the bleeding? Suppose you have a severe bleeding. I will go to Mihir that you have a severe bleeding with the EBUS scope. So whether you will keep that EBUS scope intact or you will remove the EBUS scope to have a better suction or those kind of things. Any use of Fogarty's with those kind of thing. You have a severe bleeding while you have punctured one of your nodes. So what is your way of tackling that bleeding?
So luckily, I have not had severe bleeding yet. But essentially, from all the learnings from all of the cases that we've read about, the first approach is to actually try and tamponade with the processor of the ultrasound itself at the site. If with all of that you have managed to hold on for as long, you know what the patient's coagulation is like, and essentially if you've held it for about 2 to 3 minutes and bleeding has stopped, that's great. You are likely to be okay with it. At the same time, yes, in fact, we always keep a balloon ready at the site if it is possible for you, if it is a acceptable location where you can actually manage to give tamponade with a balloon. Because if you've done a tracheal sampling, as in which is in the trachea itself, whether or not your Fogarty is going to be able to give you any kind of leverage is questionable. So that's an issue. In is there a role of keeping the EBUS scope intact? So yes, because your tamponade is going to have to remain in place. At the same time, you're probably going to have to start thinking about other ways of managing the airway. If you have a rigid available, to which will also provide some amount of tamponade on the sides, is something that you should be thinking in those directions. And uh, beyond that, I feel at the end of the day, you want to check the other parameters, whether your patient's blood pressure has spiked at the same time, your anesthetist is there, manage the hypertension if that is the case. Keep there is no real proof for any one particular drug which can be given locally, which is likely to help at most to manage. But we keep Tranexa at hand in any case if there's something that can be done from that angle. Yeah, I think that's what one would want to think about.
Yeah, Devraj, I just have a point in this because we started doing it. So basically, when you actually generally EBUS doesn't bleed much because whatever the bleeding happens gets tamponated within the node where you actually sample from. So generally, you won't see a bleed, but sometimes, very rarely, what happens is sometimes, especially when you're using this intranodal cryobiopsies, when you're trying to create a tract with a 19 gauge or even with electrosurgery, sometimes, very rarely, even whatever I'm saying is a very, very rare phenomenon. It doesn't happen that frequently. So there can be some sort of bleed may be there, like which may be a bronchial ooze. It will be continuously oozing and it will be spoiling your vision. So when such a thing happens, the best thing what you can actually do is you already have a balloon in the EBUS, like you have the covering. So you just inflate the balloon and pull it back and tamponade it wherever it is. You need not require a second Fogarty balloon to actually do it. So you just, because sometimes it's very hard to approximate your scope against the wall, and it doesn't happen because the surface will be huge. So what you do is you use the saline filled balloon and go and tamponade it, especially when you're doing it in the subcarinal region or when you're doing it in 10R region. It can actually cover that area and can provide a good amount of tamponade. This is something which we started using it, and it does help in attaining the hemostasis to a good extent.
But for that, you need to always go in with the balloon,
Yes.
So that is like a prerequisite. So balloon going with, so not many technicians are well trained in, placing the balloon.
With the balloon.
My technician, I don't know what I need to do. He still can't manage to get the air out of the balloon.
No, I completely agree with you. They are very reluctant to use the balloon. Very, very reluctant. I worked at two private institutions. At both the institution, three institutions, I found all the technicians were very reluctant to use the balloons.
We'll have to send them to Vishwesh, I guess. Yes, Ujjwal
Yeah,
sir.
I think the balloon part is something which we should be doing and not leaving it for the technician, because technicians they are not very careful in doing these things. So it is very easy to take out the air if you are a little cautious in the beginning. Number two, the balloon costs. The cost of the balloon is around, I think, around 3,500 per balloon. So that is quite a bit. So that is one of the reasons why people are not using it, but it's always advised to use with balloon, because you never know when the problem is going to come. So Vishwesan has rightly said, balloon itself is enough to control any kind of normal bleeding which happens. I do not know, we have 5 6 people over here, how many of us have ever had a significant bleed? I think probably nobody would have had. It's only the minor ooze which happens, which is easily controlled if you're doing it correctly by just opposing the balloon to the wall.
Sir, I will like to add one more important aspect of the EBUS procedure, which we have made a protocol at our center only. That is, pre and post EBUS, we always have a white light bronchoscope. So when we begin, because we use Olympus, as we all know, because the clearly mentioned reasons about the video bronchoscope and a fiber optic scope, the optics are not that great. Endoscopic vision is not that great in the EBUS scope. So what we do is first we do a check scopy. Roughly it hardly takes around 2 minutes. And always when we do the procedure, there might be some ooze, there might be some blood clots, particularly from the right bronchosector, they might have deposits into the right lobe bronchi. So we tend to go there and clean all those things. So there is no remnant infection or atelectasis and all that kind of thing. So it's just a practical point what we have added in our EBUS bronchoscopy as a protocol only. That once we do EBUS, even the minor ooze, whether there is also check scopy, check white light bronchoscopy before EBUS and after EBUS. So that questions that we don't have any significant bleed after what we do the EBUS process. And luckily, even I didn't encounter any major complications like major bleeding or anything while doing the EBUS process.
Any experience of transvascular EBUS related complications? Any one of you?
So I've done about, in the last 2 years, around 3 or 4. But touch wood, if you follow the the processes well, so the patient has to be sedated and paralyzed. There's no question of doing it in. I attempt it under conscious sedation. I give an antibiotic first before I go through the vessel, and just take one pass, and in that you do maximum 5 to 6 revolutions and out. Then I don't go in the second time. So that's about it. And I haven't tried, obviously you can't, I don't think it will be foolish to try a cryobiopsy there, but that's it. That's just about the pulmonary. That's what I do over here.
Vishwesh, Mihir, any comment?
I have never done a transvascular, and I always try to look whichever is the safest one.
Yeah.
So, and let's say you are caught up in a situation where there were a couple of instances where we had this sort of a node which is behind the aorta, and sometimes what you have to do is you have to go through the esophagus. We generally miss it. We try to go through the airway. So you can pass the same scope. We have done one such case where there was it was very adjacent to the aorta, and they sent us for a transvascular. But we were able to pass the scope into the esophagus, identify the node, take the biopsy in a much safer way, and come out with a diagnosis. I think until and unless it is really going to change the management of the patient in a big way, I don't think it is worth. I'm not discouraging anybody who is doing it, but I think safety takes precedence over the yield. Until and unless, let's say that is the only node you ever have, and diagnosing it is going to make a significant difference in your management, then yes, you follow the protocol and do it. But if you feel like that is yet another node, or even if you diagnose that it is not going to impact your line of management, then you need not do it. And the another way of doing it is you can still consult your thoracic surgeons, and they can do a mediastinoscopy and get the diagnosis done. So, and or sometimes if it is very close to your esophagus, you can go with that esophageal route and get it done. So I think as a beginner, it is not advisable. You will see all success stories, but complications will be always there. Like that is never projected in the mainstream. So I think safety is the ultimate thing when it comes to doing IP. So that's nothing that I feel.
I agree. So if people have never seen it or done it before, even once during the training, they shouldn't try transvascular. Simple as that.
Any one of you, any experience of complications while puncturing, although it is not recommended to puncture the mediastinal cyst, but in some cases where you anticipated some alternative diagnosis, you puncture the mediastinal cyst, or for identification of any pulmonary vasculature related complication. Any complications in your experience, even you did not encounter, what you heard from your colleagues or from your seniors, any experience of those kind of complication of using EBUS other than sampling from the mediastinal nodes?
So I've aspirated a cyst before, but then it reaccumulated. So I don't think so. It makes
Probably it was bronchogenic cyst, no?
the bronchogenic cyst. It was a bronchogenic cyst, and there was one cyst where it had a lot of calcium granules inside, and it was a huge cyst, which was posted for a surgical resection, but they couldn't make the patient lie down flat because it was so huge and it was compressing the pulmonary artery and the left atrium there. So that we had to go to the OT and decompress the cyst so that the surgeon could go ahead and do the surgery. So, but in those cases, since it was anyway taken out by the surgeon, we didn't get to see the complications per se. But otherwise, I usually refrain from draining a cyst just because I see it, unless it's causing symptoms or not for a surgical.
Why I ask this question, Sham, is because to know, I did not encounter any, or I did not hear any complication of mediastinitis. Did you hear any history or any complication of mediastinitis? Any one of you, Dr. Jayakumar, Ujjal sir, Visheswaran, any mediastinitis following a EBUS?
Sir,
Any pneumothorax following EBUS?
So I will explain two things. One is with respect to the cyst. As you rightly said, it's better not to adventure into doing a cyst aspiration because it's not the cure for the patient. So, but as a novice, even we have tried. Like when we started, you all get excited seeing an EBUS cyst and you end up doing it. The important precautions in case if you're doing is always a new needle. So that is the most important thing. You cannot take a reused needle and contaminate the cyst and make a sterile cyst and infected space. And second thing is post EBUS antibiotic prophylaxis is a must generally, especially when you're dealing with the cyst to prevent mediastinitis from
What
happening.
antibiotic will you recommend, sir?
It's generally a third generation cephalosporins. Third generation cephalosporins generally is what we give. But to be very honest, there is no proper guideline recommendation also, because ideally this is not indicated for the cyst only. Like you do it some very rarely when you are doubtful whether it is a cyst or it is a necrotic space or something like that, and then you realize that you actually aspirated a cyst. And third thing is, the moment you start finding a bleed, stop it. That means you have inadvertently punctured some vasculature in the cyst. These are with respect to the cyst. And the second thing, what is the one which you asked? It just skipped my mind. Debraj, you were asking one more question, right? Like
mediastinitis, sir.
Mediastinitis. Any experience of mediastinitis?
No, a mediastinitis, no, till now never. But pneumothorax, yes. So that too, how it happened was, like my associate was performing an EBUS intranodal cryobiopsy, and you can actually pick up the pneumothorax happening on table. I'll say how. Like, so for example, there was a node. The vision was very clear. Initially, she attempted taking EBUS needle passes, and it was suggestive of atypical, but we were not able to get a good core because we wanted to do the IHCs and everything on that. So the node was there and it was seen very clearly in the window. Then she attempted an intranodal cryo using an electrosurgical knife technique. This is the only case which has happened in maybe uh, thousands of cases of EBUS which we have done. This is the only case of pneumothorax which has ever happened. So what happened was she put the electrosurgical knife. We activated the knife, and after that we were not able to actually see the node. The node vision was gone. Like we were able to see only haziness. The same place you try to rotate your scope and everything, nothing was seen. So this node which was seen very clearly, now you are not seeing anything. You are seeing only like the grayscale on the EBUS image. That time we didn't realize. Then she abandoned the procedure. Later you got a X-ray. There was a pneumothorax. So what has essentially happened is air is a poor conductor of an ultrasound image. So initially you are having a good approximation between the wall and the scope, and you are able to clearly see the node. But the moment you created a pneumomediastinum followed by a pneumothorax, air has come between the scope and the node. So when air is there, you won't get an ultrasound image. This was the interpretation which we are able to get it post procedure, not during the time of the procedure. And that is the only case of pneumothorax we have ever had, like where we do almost like at least like, so in a month, let's say around 25 to 30 EBUS. That means so much of EBUS you do, still this is the only pneumothorax we had. And you can actually identify creating a pneumothorax while doing an EBUS using your ultrasound image.
So sometimes we sample when you're suspecting sarcoidosis, and as recommended, we take TBLBs and endobronchial biopsies. So as a part of the whole procedure, while taking TBLBs, you might end up having a pneumothorax.
With the rows, if you have a granuloma yield from a EBUS, still will you go for TBLB, cryo TBLB?
No. If we have a diagnosis, we would stop.
Yes. This question, and then we will have parting comments from all of you. So many of the patients nowadays are on newer anticoagulants. So with EcoSpring, with clopidogrel, we had much clarity for how many days we need to stop. And the problem with NOACs and all those things, patient of atrial fibrillation, it is very difficult. When a cardiologist will never advise you to stop the NOACs. So for whatever procedure you are doing. So for how many days you follow for it, be it EBUS or be it a cryobiopsy or be it any kind of thoracoscopy. So for what is your experience with the NOACs? And also with the direct thrombin inhibitors, which also nowadays many patients are right now on.
Yeah, Debraj, again, one more thing, interesting thing which we started doing with this. That's why I thought I will say my experience and hear from other panelists. So NOACs, I think generally the cardiologists say like 48 hours, 48 to 72 hours is what they say. But there are certain NOACs they ask us to, for example, Brilinta or something like that, if they are on such anticoagulation.
Yes.
Yeah, we stop for at least 5 days is what they say.
I asked this question specifically for Brilinta, to be more precise.
Yeah, so I think it is 5 days. That is what my cardiologist asked us to stop. But the interesting thing is, we are always worried, like once we stop this anticoagulation, what if the patient develops a complication of stopping anticoagulation within these 2 days? So what we do is we overlap with heparin. So the advantage of heparin is you just have to stop it like 6 hours or something before the procedure. So we stop this anticoagulation, overlap these patients on heparin.
Then you need to have this patient admitted. I mean, it is very challenging to take heparin at home.
Subcutaneous heparin they can take.
I agree it can be given subcut, but if you take the real-time situation into account, it is very difficult to convince the patient to take heparin once daily, even at home.
Yeah, but we have done that in we have done that in few cases. That's why I thought I'll bring up this point. Because you are always afraid. Like, let's say I stop an anticoagulation patient. What if a patient develops a stent thrombus or a clot in the left atrium and then develops a stroke? So if you have such high risk cases, what you can do is you can stop these NOACs as per the prescribed duration, depending upon what Novax you are using, and then overlap it with a heparin, and then you can stop the heparin like few hours before the procedure, and you can safely do a procedure.
And any roll up, any having some, because they do not have any reversal agents. So do you keep FFP and all those things in hand, or factors?
So generally the EBUS is a very safe procedure,
I'm not
and most of
asking
the time bleeding never
specifically about
occurs.
EBUS,
Yeah.
but in general.
Yeah. For others, yes. For others, let's say you are doing a tumor debulking or something, you have to keep the reserved blood products in the back before the procedure only. We do that.
Now, last question to Ujjal sir. Sir, regarding the rows, how important it is for a pulmonologist to learn rows? For a
First of
pulmonologist to learn rows.
See, first of all, the advantages of rows is that you can decrease the time that you're spending doing the procedure, especially when you're doing staging. So that is the probably the only advantage of doing a rose. And a pulmonologist can easily learn. We at our institute have started doing that, and we have found that it's very easy to do, and that can decrease the time that we spend doing the procedure. But saying this, we need to identify certain cells, and that's very easy. A few days with a good cytopathologist is good enough to understand what these cells look like, and then you can start doing it in your bronchoscopy suite. But the problem with rows is not this only. The problem with rows is that at times you may, when you're dealing especially with smaller nodes and doing staging, you may feel that this is enough. But when you send it to the pathologist, they say, no, we're not seeing this. It is not enough. So at times, rows may not help. You still have to do your procedure completely. If you have to take 4 or 5 passes, you have to take 4 or 5 passes from there. At times, I have found that Rose has at times given us a problem that we have stopped this, and we found atypical cells in this. And then when it goes to the pathologist, they say that no, we're not. It's not conclusive. So you get some more material. So what we have started doing is that we are doing Rose, and when subsequent passes are also showing the same thing, then only we stop. We're not stopping after one pass. And if it shows, so that is what we are doing. Rose is something which everybody can learn very easily, provided we have that much amount of time and the infrastructure.
Excellent, sir. So parting comment from all of you, and we will start with Dr. Vishwesh.
So EBUS is the easiest of all the interventional procedures to learn, and there's nothing to be scared about doing an EBUS. As I said before as well, the only thing you should be scared is how to protect your scope from needle damage, because it's a very costly scope to handle. But the fear of doing should never stop you from doing it. I think it is a very easy procedure to do, and once you have good proctor and a mentor to teach for 1 to 3 months, I think you should be really good enough to start doing an EBUS.
So my take on it is that it's a very handy thing, and I feel it's totally taken mediastinoscopy outside the realm. It has a very extremely few indications left. It's a very easy, I would say, a relatively easy skill to learn if you know bronchoscopy, and it helps our patients tremendously. I mean, if you see the bulk of IP, if you take bronchoscopy, thoracoscopy, and flexible bronch, thoracoscopy, and EBUS, they account for, like, I would say, 80% of our procedures. So I feel this should be, definitely it's a skill set need to be learned by all pulmonologists.
Dr. Jayakumar.
So I think EBUS has now become like a routine procedure, interventional pulmonary procedure. And I think with the dissemination of the knowledge, particularly with this type of webinar series from the CCI, I think many of our budding pulmonologists will like to do that, having hands-on. And from becoming a bronchoscopist to an EBUS bronchoscopist is a journey. And I think it's a very rewarding journey. And one must, as an interventional pulmonology, has to endure this and get this skill. So I learned so much from the esteemed panelists. Thank you so much for the experience sharing.
Ujjal sir.
I would say that EBUS is a good diagnostic procedure, and it should not. My take is it should not be being into the IP. It is outside the IP. We are not doing too much of intervention. We are just taking sample from a lymph node. So it is just like an extension of bronchoscopy, which is doing endobronchial work, and this is doing the extra bronchial work. So it's probably not an IP. So therefore, whosoever is not doing IP can still go and do EBUS. It will increase their knowledge about what the patient is suffering and probably improve the patient outcome. That is one. Number two, it's a very easy procedure, as Dr. Vishweswaran has said, and therefore reaching the same kind of efficiency as an expert is very easy. And very quickly, you can achieve those kind of numbers of 90%, 95% yield and the specificity. So it's very rewarding also. So everybody should learn it. And now, and with the knowledge that we have gained over last 15 years, I think probably every bigger hospital is having an EBUS scope. So there is no shortage of this instrument around you. Go learn it and then have it.
Mir.
I agree with everyone that it's a mainstream procedure now, and you must know how to do it. Possibly the only thing that I can add is that when you start doing your procedures, probably keep an audit of the procedures you're doing. Understand when you're not getting a yield or you get a negative result, when you're expecting something, as to what possibly went wrong, and try and correct those to try and match the kind of yields that are reported everywhere around the country and around the globe. And though the presentation was on complications, very, very low complication rate, and hopefully nobody needs to really face any complication of this sort.
So thank you very much. Good night to everyone. And thanks to CCI, Dr. Krishna, everyone for giving us the opportunity to talk on a real life experience of using the EBUS scope, how to make a EBUS suit, what are the advantages of different scopes and different needles, comparative analysis, and parting comments from everyone. Only thing what I want to say is that we need more trainers like Dr. Vishweswaran, Sham, Ujjal Sir, Jai Kumar, and Mihir, and we all request Dr. Vishweswaran to organize more conferences now, which he has stopped nowadays.
So definitely we'll organize soon. Thank you, Debraj sir, and thank you, NH Krishna sir and CCA for an excellent initiative. I think it would benefit the youngsters more.
Thank you, sir.